to chair this session. So this is going to be a dynamic session. We're looking at clinical trials for biliary tract cancer. I'm going to introduce our three speakers, and then we'll ask that you hold your questions until the end of the three talks. They're going to be about 15 minutes each, because once they finish until about noon, we're going to have a panel discussion. So please, there'll be lots of time to ask questions. So our first speaker is going to be Dr. Arndt Vogel. We know him as a medical oncologist at Princess Margaret Cancer Center and prior to this practice in Germany. And he's currently the chair of the Longo Family Liver Cancer Research Program. So happy to have him. And then Dr. Taggar, radiation oncologist at Sunnybrook Hospital, very active member of our provincial C3 boards. I would describe him as a think outside the box radiation oncologist. It's great to have him, always trying to push the role of radiation. And Dr. Jennifer Knox, medical oncologist at PMH as well, and we all know her very well. And I would have to say we need to give a big round of applause. She was the medical oncologist that went back again and again about getting pemigatinib funded. She was relentless, and we thank her. So. All right, so we'll have Dr. Vogel come up as the first speaker. Thank you.
Yeah, thank you very much for inviting me, and thank you very much for C3. I think it's really very important, and it really helps us, I think, to improve outcome and future research for cholangiocarcinoma for this really devastating disease. And I would like to give you an overview on where we are at the moment. And just a couple of weeks ago, we have published the ESMO guideline where we kind of summarized the treatment algorithm for this disease. And without going into too many details, I think it's very clear that it's getting really complicated. It's a rare tumor, but we do have more and more options, which is good. But still, we need to do better to really improve outcome. And what is really important is that we really have a multidisciplinary tumor board where we discuss all patients and discuss what is the best next option for each of our patients, from patients with local disease, which may be candidates for surgery, where we need to improve outcome after surgery. I think we have heard a lot about molecular profiling, and I think this is really critically important because we have so many targets, which are all highlighted here below, for which we have targeted therapies available, which can also improve outcome. And I will come back to this later in my talk. Again, here, this is an overview. When we talk about BTC, we have to distinguish different types. In general, we distinguished intrahepatic, extrahepatic, and gallbladder carcinoma. I think that's probably more important in the future because we know that there are different genetic profiles for the different tumors. And you can see here on the right-hand side, these are the most frequent drivers, which basically initiate tumor development. And we are trying to target these drivers to improve outcome and improve survival. And we are getting really more and more successful. And I will show you in a minute how this looks like. But starting at the first point, and I think initially we need to do better, right? Even after surgery, which we consider as a curative treatment, we know that the risk of tumor recurrence is very high. And we try to improve outcome by adding chemotherapy as we do it for other tumor types. We have a study from the UK which indicated if we provide capecitabine, a drug after resection, we can improve outcome, but it's not really convincing. And what we are now trying to do is to use more and more effective chemotherapy, such as, for example, gemcitabine cisplatin. And there was a large study that was initiated in Germany a couple of years ago, which has now finally finished recruitment, and we will learn whether we can basically improve outcome when we use more chemotherapy after resection. That I think will be very important. What we also have learned is that we can activate the immune system to fight the tumor, and this is something we are trying also in this adjuvant setting. So after patients receiving a resection of the tumor, we have now initiated a clinical trial where we add chemotherapy, which is our standard of care, but we also add a so-called bispecific antibody, which is meant to activate the immune system. traditionally fight the cancer cells in addition to the traditional chemotherapy. And this study recruits in Toronto as well. And so whenever a patient gets resection, I think we definitely should try to include him into this trial because I think it has the chance to really improve outcome after resection. And I have mentioned before that we have so many targeted therapies in BTC, and at this point in time, we are using them mainly in second and third line when we do not use chemotherapy anymore. And some of our colleagues in France have initiated a study where we are trying to use these targeted therapies in the adjuvant setting. So once patient get a resection and they recover from surgery, they get their traditional chemotherapy, but then according to their genetic profiles, they get targeted therapies. And I'm trying to work very hard that we get this trial also to Canada. We most likely we will initiate it very soon in Europe, and hopefully we can also bring it to Canada because this, I think, a very good opportunity to really use these very effective drugs very early in the setting. And I think with that, we have a chance to cure more patients after resection. What we are also trying to do is to improve outcome by changing the order of treatment. So traditionally, we have started with resection and then added chemotherapy after surgery. But we know that not all patients are really fit enough to get chemotherapy after resection. And what we are now trying to do, as in other tumors like gastric cancer, that we start with the chemotherapy. And once this has been done, we proceed to surgery. And this is a study that Gonzalo Zapizochin and myself have initiated, and hopefully we will start later this year, the so-called Cholangiocarcinoma trial, where we are using really an intensive chemotherapy triplet regimen plus this bispecific antibody, which is also evaluated in the adjuvant setting. So a combination of chemo and immunotherapy to, again, improve outcome after resection. So the next step, and when we think about the tumors, we have these small tumors, which can go to resection. But we also have tumors which may be too big to be resected, but still are confined to the liver. And here we are trying to understand whether we can also use local therapies to improve outcome. And one local therapy that is unfortunately not available here or not improved or not reimbursed here is Y90, which we also use in hepatocellular carcinoma. And we have good data now that using Y90 for liver-limited cholangiocarcinoma may be helpful and improve outcome. Of course, we need clinical trials to improve that. And this is another study which we are recruiting in Germany at the moment, where we combine Y90 with immunotherapy. Again, you can see immunotherapy is really a very important part of our treatment strategies at the moment. And these trials are really extremely difficult to recruit. You can see here, I started this trial almost 5 years ago, actually, and we are now getting closely to the end. 45 or 50 patients have been recruited. We have included other centers in Spain, and now we are really getting at the final stretch. And I think hopefully this study will help us to really get more evidence that it's really meaningful to combine local therapies and immunotherapies for these liver-limited tumors. When you now think about the next step, we have learned, chemotherapy improves survival. It adds, and when we use doublet chemotherapy, GEM-CIS, we can improve outcome. And what we have also learned is that when we add a checkpoint inhibitor, and we have 2 large phase 3 studies, we can further improve outcome. And with that, we have a new standard of care. And we're using now for all of our patients GEM-CIS and a checkpoint inhibitor in the first-line settings. One question is, can we use the checkpoint inhibitors only with gemcitabine cisplatin? And we know that some patients are not really good candidates for this kind of chemotherapy. And therefore, we are performing a phase 3B study where basically all patients get the checkpoint inhibitors, but they can get other chemotherapy backbone. So if they have contraindications against specific chemotherapies, we can use, if they have contraindications against GEM-CIS, we can use other chemotherapies. And I think this will also help to more broadly use the checkpoint inhibitors in the first-line setting. So coming now to the targeted therapies. Again, I mentioned already for intrahepatic cholangiocarcinoma, we have a slightly different profile of genetic alterations compared to extrahepatic cholangiocarcinoma. For example, you can see here we have the FGFR2 fusions, IDH1 mutations very frequently in intrahepatic cholangiocarcinoma, and they can hardly be found in extrahepatic cholangiocarcinoma. So we need to be more precise. What kind of tumor do we have? And then, depending on extra versus intra, we should do the genetic profiling. Generally, we would recommend to do really broad profiling to identify these genetic alterations. And here on the right-hand side, you can see we have now a lot of drugs that can really target these drivers, and they can improve outcome. And I will show you in a minute how. And one, and this has been mentioned before, one target are the FGFR2 fusions, which have been evaluated for really a couple of years. And I think the study with pemigatinib, which I presented at ESMO 6 years ago, was one of the first studies which has shown that we can really achieve deep responses when we use pemigatinib in patients with FGFR2 fusions, as you can see here. And then you can see that a couple of newer drugs have been developed since then, and they have a very consistent picture. We have a very good disease control. We can achieve a lot of remissions with these tumors, and therefore they have been approved by basically all regulatory agencies all over the world, and they're used in clinical practice in many countries. So it's hard to understand why we cannot use pemigatinib here in Canada so far, and which brings me to another point, which is basically we not only need to do research to find new drugs, but we also need to make them available. And this is something Angela Lamarca and myself have thought about for a long time. And this is the paper we published 2 years ago, when we basically looked, so how long does it take that a drug becomes available in a specific country? And that was in September 2023. And you can see this was already almost 3 years or more than 2 years after approval of pemigatinib. So the regulatory agencies have already said it is an active drug. And you think, okay, if it's an active drug, so let us use it, right? I mean, so why not? And you can see when we look, and this was focused on Europe, there were a couple of countries in which it was available, but there were still some countries in which it was not available. And at the same time, pemigatinib, the second FGFR inhibitor, was also approved for more than 6 months. And you can see at that time, only Germany and Austria have reimbursed pemigatinib. So there are definitely 2 points. One is we need to do research to find new drugs. We need to do clinical trials to show that they are effective. But then we need to make these drugs available, and our regulatory agencies need to approve and reimburse these drugs. And as you know, it's still not reimbursed here as of today. This 5 years after, 6 years after I presented the study, 4 years, March 2021, since it has been approved by EMA. Yesterday, we got the positive news, and it's hard to say it's a positive news, but we finally got the news that even Canada is now considering to reimburse pemigatinib, which is definitely good, and we need to make this drug available here. But I think we need to do better and make these drugs faster available. So I am obviously very critical about this approach, but we also have to acknowledge why it takes so long to approve drugs, right? And what we have seen before, and this is a dilemma what we have, that we have, this is a study we conducted, which I conducted in Europe, and we looked at the outcome of patients with cholangiocarcinomas and tried to understand what is the impact of targeted therapies. And what we can say, and these are the most frequent targets for which we have drugs available in principle. And you can see that outcome is definitely better. So patients live much longer if they get targeted therapy. So it's definitely meaningful to provide these targeted therapies. But the problem is, in many of these trials, we do not have a control group. So we don't really know what does it mean to have an FGFR2 fusion. Is it maybe by itself something that changes the biology of the tumor and patients just do good, right? I don't think that they would shrink the tumor. Yeah, so I have never seen this before. But maybe tumors are growing faster, and the prognosis of these tumors is better. And therefore, I think it's important that we understand, and this is, I think, also our duty as physicians that we generate data to understand what are the implications of these tumors. Yeah, and with our cohort, we looked at, you can see FGFR2 fusion and IDH1 mutations are the most frequent alterations. And what we can see here, this in gray are the patients without FGFR2 fusions. Here, this in blue are patients with FGFR2 fusions not receiving targeted therapies. And you can see they do a little bit better. So maybe there are indeed prognostic implications. And of course, I can understand the payers asking us, is there really a benefit, right? So, and I think we need to generate these data. And you can see here in yellow, these are the patients that receive targeted therapies, and they live 10 months longer, 32 months compared to 22 months. I think it proves that these FGFR inhibitors do have a benefit, right? I'm not really sure whether countries should take 5 years, 6 years time to not provide these drugs because of these doubts. I think these doubts are fair, but I think we need to generate other methods to make these drugs faster available. Yeah, and the same for IDH1 mutations. I've used these drugs for a couple of years in Germany, and I still can't use it here. Like you can see clearly, patients live almost twice as long with IDH1 inhibitors compared to those that are not able to receive it. So there's clearly a benefit. And I think we need to make this drug available also here in Canada. Another point, which is also important, I have just mentioned FGFR2 fusions. Maybe they do better than patients without fusions, but maybe it can be even worse, which means that the prognosis of these patients is worse compared to patients without this mutation. And here are 2 examples, and I think this is really concerning. In gray, you can see here the survival of patients without HER2 amplification, and here without BRAF mutations. And you can see patients that have these alterations do really clearly do worse compared to those without these mutations. So if you have a BRAF mutation or HER2 amplification, outcome may be even worse compared to those without these mutations, right? And when you now look at the outcome of those patients treated with targeted therapies here in yellow, you can see they do much better. I mean, just look at this 7.4 months survival for patients with BRAF mutations not getting therapies compared to over 30 months for those getting targeted therapies. I think these data speaks for themselves, and I mean, leave us at a place where we really need to think about how can we address this. And I think this is really something we need to work on. The problem is, we looked at 1,500 patients, right? 18 centers, and we identified 30 patients in each group. So this is a rare tumor with rare subgroups. It's extremely difficult to do research for these few patients, but I think we need to do it. If you look at this, it's devastating, right? We know that there are drugs available and we cannot use them here. So this is something we definitely need to change. How can we change it? I mean, what we tried at PMH is to bring clinical trials to Canada. One trial is with futibatinib. It is approved, as I have shown you, for many years. But still, if the drug is not reimbursed, we cannot use it. And now we have here a trial where they basically look at different drug concentration, 20 milligrams compared to 60 milligrams. I'm not really sure whether this is a meaningful trial, but when we can use this trial to bring the drug to Canada, I think it's fair to participate, and all these patients will get futibatinib. So I think hopefully we can open soon, and then we can also include patients in this clinical trial. Another way is the PROVIDE study. I mentioned IDH1. I've shown you that IDH1 mutant tumors are sensitive to IDH1 inhibitors. There's luckily a phase 3b study which can use to provide ivosidenib to patients. Yeah, so again, this is another trial where we basically use trials to provide treatment to our patients. Here we look and try to get more data on safety and efficacy, which is, I think, fair. We do need these data, and for us, it's a nice opportunity to provide ivosidenib to our patients. So how will we proceed in the future? One way is that what we are trying is to bring these targeted therapies to earlier settings. At the moment, we are using them at 2nd or 3rd line. And here is one trial where we are trying to basically combine everything we have into the first-line setting. So chemotherapy, immunotherapy, and targeted therapies against HER2, which I think is really exciting. And I've shown you these really poor outcomes for patients having an HER2 amplification. So we urgently need to do something for these patients. And I think this is a very interesting trial. And I can only ask you that we really advocate that every patient with a newly diagnosed cholangiocarcinoma should get an immunohistochemistry for HER2 so that we can identify and include these patients into this trial. Because again, we don't have targeted therapies against HER2 available in second or third line here in Canada. So it's really a good opportunity to participate in that. And this is also an approach we are using for other drugs. Ivosidenib, I have showed you before, we have the data from a phase 3 study. It's available in many countries. We are participating in the phase 3b study, so we can offer it in second and third line. And what we are now trying to do is to combine it again with chemotherapy and immunotherapy in the first line setting to further improve outcome. And I think that's very exciting, and hopefully we will start this study soon. Again, highlighting how important it is, and I'm really thankful to C3 that we can offer molecular testing in a timely way so that we can also include patients into this study. And there are different approaches. This is an example from another study where we are trying to combine FGFR inhibitors in immunotherapy. I think this is the new wave, what we are trying, that we bring these targeted therapies, which we have used as monotherapy in second and third line, to earlier lines of therapy and combine it with either immunotherapy or immunotherapy and chemotherapy. And the other point is, I mean, even though we are pretty excited about these targeted therapies, we also have to acknowledge that we cannot control these tumors forever, unfortunately, and eventually they develop resistance. So we need to overcome resistance. And this has been nicely studied for FGFR2 fusions. And what we have learned is then if patients have these FGFR2 fusion, usually the inhibitor can bind here. However, the tumor cells change again and again, and they develop additional mutations like this one here. And with that, the protein or the drug cannot bind anymore. And with that, it loses efficacy. So we need to overcome this. And one way to overcome this would be to use new drugs, which can still bind to the fusion protein despite having these mutations. And this is one of these drugs, is tinangotinib, which will offer us the opportunity to use not only pemigatinib or futibatinib in the kind of first-line setting, but also use another drug, also targeting these FGFR2 fusions in the second-line setting. And with that, we can further improve outcomes. So I think that's very exciting that we are really understanding resistance mechanism and trying to overcome resistance mechanism. And this study is recruiting in most countries worldwide. Unfortunately, not here because we do not have first-line patients, right? Because pemigatinib is not available. But the study is recruiting in the US, and whenever we have patients, we also try to bring them to the US that they can start and participate in this clinical trial, which I think is a very good option to really extend the opportunities we have for patients with FGFR2 fusions. So the last slide is in which the last direction we are heading. So far, we have talked about chemotherapy, immunotherapy, and the so-called targeted therapies. And the next big wave will be the targeted chemotherapy. And targeted chemotherapy means that we are using antibodies to target specific proteins on the tumor cells, like Claudin 18.2. And on this antibody, we have chemotherapy coupled. Yeah, and with that, we are really trying to deliver high dose of chemotherapy exactly to the tumor cells. And there's a study that has been initiated by AstraZeneca, and they have a basket trial for multiple tumor types. And interestingly, they are also going to open this trial for cholangiocarcinomas. Around 10% of patients with cholangiocarcinoma have Claudin 18.2 overexpression. So it's again a small subgroup of a rare tumor. Yeah, but I think it will offer more to our armamentarium to really target these tumors. And this is my last slide. So I think it's complicated already. It's going to be more complicated in the future, but this also means hope because you can improve outcome for our patients. Thank you very much.
Okay, thank you. So Dr. Vogel, we have to step out for a few minutes just to run his other trials. He has a trials meeting he has to jump onto, but we'll come back as soon as he can. So we're going to have Dr. Taggar come up at this point. Thank you.
Thank you very much. We'll have my slides up. I'm not. Oh, ah, there you go. So to introduce myself, I'm a radiation oncologist. I'm not a medical oncologist. I will not talk about as detailed trials, but the job that was given to me is to discuss potentially local therapy trials. And I have a disclaimer, there aren't that many local therapy trials. So what I'm going to probably do is talk about local therapies for cholangiocarcinoma. As a radiation oncologist, I will focus on radiation, but we'll discuss some old, new, and future therapies. This is our learning objective today. This is a heterogeneous group of audience, so we want to learn about radiotherapy in cancer, especially in bile duct cancers, trying to differentiate between intrahepatic and extrahepatic bile duct cancers, what's there. I am a self-proclaimed interventional radiation oncologist. That means I do brachytherapy, so we'll talk about that. Maybe some of you have heard of brachytherapy in our Sunnybrook trial. And I will also discuss some of the interventional procedures such as TACE, AIR, and I'll go through those details and perhaps the HAPE. I do have some of my colleagues in the audience who will talk in more detail later. And I've been asked to discuss histotripsy as well. I'll have one slide on that, and perhaps I can take some questions afterwards. To go over just the anatomy again, I know Ravi has gone through it, and some of my previous colleagues have gone through it. In my estimation, looking at previous years of data, there's about 750 cases per year of cholangiocarcinoma, specifically intrahepatic cholangiocarcinoma in Canada. And when you combine with some of the others, remember, extrahepatic cholangiocarcinomas are listed with others, and you're trying to tease out, there's only about 1,500 cases per year of these other cancers in Canada. So this is a rare cancer, although we've seen from Ravi's slides that incidence is growing. And how do you differentiate if it is inside the parenchyma of the liver, inside the parenchyma of the liver, we call it intrahepatic. Once those bile ducts are outside of the liver parenchyma, when they start to become what we call just a trunk or common hepatic duct, that's when we call them hilar cholangiocarcinoma, and anything outside is extrahepatic cholangiocarcinoma. And when we think of different therapies that we can potentially offer to our patients, intrahepatic cholangiocarcinoma, we often think local therapies. If the tumor is limited, solitary, and is technically resectable, surgery is primary treatment. And we heard from Dr. Vogel, perhaps we can introduce some of the chemotherapy drugs before surgery. Oftentimes we do it after surgery, as most of our data is after the surgery. If surgery is not feasible, we often think of other local therapies such as TACE or radioembolization, talked about Y90, that's also called TARE. Radiation, either external beam radiation, that's the most common form of radiation, many of you have heard, is one of the other options. And ablation, you may have heard radiofrequency ablation from your physician or in our tumor boards. When we talk about regional spread of cancer, either more sites within the liver or the lymph nodes, the cancer has actually now gone outside, we start to think of systemic therapies, either chemotherapy, immunotherapy, target therapy, or any other sort of combinations of those four things. We can still employ some of the regional or local therapies such as TACE, TARE, or radiation. And I will give you a patient example here as well, or perhaps a hepatic arterial infusion pump. Again, this is listed on my slide, but this will be talked later. And transplant, I'm not going to go into transplant at all, but that is one of the options that's being offered for patients with specifically hilar cholangiocarcinoma, which we consider a regional disease. And when the cancer is spread outside of the liver and outside of the lymph nodes, we often talk about systemic therapies, and that's where the clinical trials are really, really effective or comes into play. So just focusing mostly on the non-surgical liver-directed therapies for unresectable intrahepatic cholangiocarcinoma. So my first part of the talk will be just on the intrahepatic cholangiocarcinoma. We think of radiation. Oftentimes we think of conventional radiation or hypofractionated, and I'll go through the details of that, and brachytherapy, and then TACE, TARE, and HAPE. Conventional radiation with or without chemotherapy. We often think of patients going for radiation, they go for 25, 30 treatments. That's delivered in a very small dose every day. The radiation can be delivered with X-rays. That's the only type of radiation we have in Canada, or protons. There's a lot of research and clinical trials in the US where they've been using proton, especially for liver cancers. Patients may receive chemotherapy with their radiation. So you get either a pill every day, or you get combination of 2 drugs every 1, 2, or 3 weeks. When we look at all the data, and there's not that much prospective phase 3 data. There's a slide earlier about phase 3 data. Most of this data is retrospective, or we can probably classify as real world data. Everybody who walks into the clinic who gets that treatment, and then the clinicians look at their patients and present that data. The survival for the patients who undergo chemotherapy and or radiation, because they have no other options, this is the only treatment, somewhere on average between 9 to 22 months. So despite all this intensive treatment over many weeks, patients unfortunately only live limited time. One of the things that came out of that, most of the data, is if you can deliver high dose of radiation. Now, radiation is a single tool, unlike drugs or medications, where you can actually potentially have targets that if one target, one chemotherapy, one drug doesn't work, can we look for another target? Maybe that will work. Radiation is single. It's X-rays and X-rays. That's it. The only thing we can do is how we can deliver perhaps higher dose of radiation, which may effectively kill more cancer cells. Over the last 2 decades, the technological advances in doing the CT scans and able to visualize the tumors in real time when you're delivering that treatment has allowed us radiation oncologists and physicians to give additional dose or maybe higher dose. And so if you can deliver higher effective dose, that actually does improve survival in patients. And I call it ablative radiotherapy, Arndt. It's different names. You've heard stereotactic, SBRT, SABR, stereotactic ablative radiotherapy. So how you deliver it, if you can give that ablative dose that you want to ablate as many cancer cells as possible, that effective dose, the magic number seems to be about 80 gray. And you can deliver it in 5 treatments, you can deliver it 15 treatments, you can deliver it in 25 treatments. There was a really good publication from MD Anderson, and both of these studies are from MD Anderson, one using X-rays, other using protons. They demonstrated the same thing. If you can give more than 80 gray, you can deliver higher dose, you can improve patient survival. And this is my patient, and we employed the same technique. This is a gentleman, 67-year-old man, came in with intrahepatic cholangiocarcinoma, was admitted to the hospital for at least 3 months because the tumor was so big, it was extending right into the hilum. It was intrahepatic, but it went into the hilum, went into the bile ducts. And bilirubin was up in 300s and 400s. It was unresectable. My colleagues in medical oncology was unable to give any chemotherapy because bilirubin was very high. Eventually, they asked me, as my introduction said, you think outside the box. We did start thinking outside the box. How can we help this patient so that we can get him to chemotherapy, get him to clinical trials? That's our first step. We did deliver the effective dose, 67 gray numbers, but effective dose that was delivered that we think to the tumor was 97 gray, close to 100 gray, instead of 80 gray. We were above that threshold. So what is the impact? So this is just pictures, perhaps maybe to illustrate that on top is July 2024 when the patient actually presented initially to the hospital. These are CT slides. On your left-hand side, you can see is the axial. We're cutting the patient just through like this. In the middle is one slice looking at patient straight in front. And on the most right is that one picture I wanted to show right where the bile duct is, where the little markers are, that's the bile duct. The tumor was going right into the bile duct. By November, he was still in the hospital. Our colleagues have tried to put in drains into the bile duct. We've seen that patients who present with these cholangiocarcinoma, they get drains. But it was not going anywhere. They asked me if we can do something. We delivered that radiation, the plan I showed you before. At the very bottom is January 26th. You can pictorially see that the actually tumor started to shrink from November to January, both in the axial slice and in coronal slice. And I want to point to the picture on the very last one where there's a drain, the white, shiny, squiggly line. That's big bile duct, and the drain can't go in. That's all filled with tumor. And the very bottom, the bile duct is now open. And this is the demonstration of patient's bilirubin. It started at 500. It was still in 300-400s in November. The green arrow in the middle is pointing when we gave the radiation for 15 days. And in January, at the very end, is when his bilirubin is now. He just started chemotherapy 2 weeks ago, and he was unable to start chemotherapy all this time before. So I'm hopeful that he would be one of those patients, but perhaps can live a lot longer and can access a lot of other targeted agents. So why don't we do any trials in clinical radiotherapy? There was a very good phase 3 randomized trial looking to deliver that kind of high dose of radiation in US. Trials started perhaps 10 years ago now, 2015. They were target of 146 patients. They could only get 5 or 10 patients in 2 or 3 years. I'm not sure if it was the access or the equipoise. It was terminated due to poor accrual. So we don't have that trial. The only other trial, as Ravi said, I also troll trials.gov. The only other trial that's available for patients is in China for high dose of radiation. So at present, there's no other trial for high dose of radiation currently available in Canada. But we do it off trial if you think it's the right thing to do. And this is my concept, and I know this is also going through. One of my other colleagues is putting some grants for this. I think we can potentially do this. We need to be able to think that we should do these best systemic therapy, either chemotherapy, targeted agent, immunotherapy. If the patient is able to proceed with that, should go ahead. And then give ablative therapy, then maybe add more systemic therapy afterwards. If the patient is unable to proceed with systemic therapy or chemotherapy, give ablative therapy, just like we did for my patient, and then proceed with systemic therapy. So I think these are the concepts we need to probably polish more. This is a very simple schema, but perhaps we can move forward. This is interstitial brachytherapy. I know Dr. Vogel is from Germany. Germany is very aggressive in delivering by putting us needle, just like patients who have RFA or other techniques. They will put a needle right inside the tumor to deliver high dose of radiation, even higher than what I can deliver with external radiation, and kill as many cancer cells as possible. So can we bring that here? Perhaps, but we need to do those trials here. We can't just introduce. Your colleague Stephanie Corradini in Germany does this quite a bit. So from radiation, I'm going to move on to embolization aspects to TACE and TEER, which you probably have some questions. What is embolization? Anytime you can, our interventional radiology colleagues can introduce a catheter right into the hepatic artery, what they can do then is isolate which of those hepatic artery is feeding the tumor. Oftentimes in liver, we have 2 different blood supplies. One comes directly from our heart, which is the artery. The other one comes from the gut, the portal system. Most often, these tumors are actually fed by the arterial system. So So that's the advantage our interventional radiologists can take. They can introduce this catheter, which is the white catheter with hepatic artery, and introduce things like chemotherapy agents, either chemo alone or combined or beaded chemotherapy called the Biliary. You may have heard that term, or some kind of radioligands, which means these are small molecules that can deliver radiation in a very, very small area, such as Y90. It's called TARE. So we have been employing these kinds of techniques in many cancers over years, especially TACE, as well as TARE, at least in the last decade or 15 years. When we look at TACE, the transarterial chemoembolization in patients who are treated with that, and I've looked at all different studies and systematic reviews, this is one of the most recent systematic review and trial, overall response rate is 10 to 15%. We can say that if you can deliver high dose of chemo, even in the tumor, perhaps those chemo drugs are not effective. You need to think of other things. The best trial that I could find was a phase 2 trial. It was not even a phase 3, Deltic trial, 48 patients who were treated with chemotherapy, systemic chemotherapy plus TACE. They did do better. Overall response rate was significantly higher, almost double. There was a downsizing of the tumor. So can we employ these methods here? I think so. And we already are in clinic. TARE, the transarterial radioembolization, when you look at all the studies, I know Dr. Vogel talked about one of the trials they were doing in Germany. The overall response rate is somewhere between 6% to 50%. So it's not that every patient will respond to that radiation if it's delivered right. And the main difference that I found in my readings and literature is because if the cancer is forming like a big tumor or mass supplied by blood, you can actually have a better response. Whereas if it's an infiltrative cancer with cholangiocarcinoma, we know this cancer can go along the bile ducts, even small ones. Generally, those don't do as well. And the best trial out of the whole studies that I did was this MISPEC trial, again, small number of patients, 41 patients, where they used the chemotherapy plus TARE together to elicit much better response. Are there any ongoing trials for these right now? Similar to the radiation aspect, this was a trial from I think it was a US trial where they used the GemCis and TARE for unresectable intrahepatic cholangiocarcinoma. Started in 2015. Accrual target was about 100 patients, but they only accrued 6 patients in this whole. And it was also terminated to poor accrual. The only other TARE trial that's open that I could find was this Emerald Y90, sponsored by AstraZeneca, but this is only open to HCC. And we know that in Canada right now, Y90 is only approved for HCC and perhaps some of the metastatic disease. It's not approved for cholangiocarcinoma. So advocacy is key. To ask them to open this trial to other cancers as well, right? So it's run by industry. And the last trial that I found that was open is in China, again, combining TACE with targeted immune therapies. Perhaps we can utilize what we know about the targets and the immune therapy and use them with TACE, not just the chemotherapy. We showed that the chemotherapy actually improves survival. Well, what if we target additional? So histotripsy, very, very brief. One slide only because it's all the buzzword right now, and I've heard it a few times, even in this meeting. So what is histotripsy? Histotripsy is a focused, high-frequency ultrasound. Oftentimes, this is the same technique we use for sometimes treating prostate cancer. You've heard of HIFU as a way to treat prostate cancer. The difference in histotripsy is in HIFU, there's a thermal aspect of that high-frequency ultrasound. In the histotripsy aspect, there is no heat. There's no thermal aspect. It's mechanically breaking down the cells rather than using the heat to kill the cells. It's a non-invasive, usually ultrasound. On the diagram that you see, there's a water bath. That's the little light blue color, and in the white machine that's on the top, the ultrasound probe is a very tiny little probe that's sticking out like a crescent moon underneath. And it delivers a very high frequency, small pulses that mechanically breaks the cancer cells. There was a trial of 40 patients in Europe. It's called Hope for Liver in Europe. Efficacy was about 94%. 42 out of 44 tumors that was treated in 40 patients did show response, and FDA approved this as in 2023. They have an ongoing trial in the US called Hope for Liver US right now, and that's the only place this trial is open. And we don't have this available because we don't know what the long-term implications are. This only started about 3-4 years ago. And finally, the last, for intrahepatic cholangiocarcinoma, the most common indication right now is the colorectal metastasis to the liver. Our team at Sunnybrook Hospital in Toronto has been doing this for a long time. There is a lot of emerging data for intrahepatic cholangiocarcinoma in the last decade. And that's the only line I'm going to say, because we have a full panel by Dr. Karen Nicholas and Dr. Rachel in the evening talking about HAPE. So making your choice. There are so many options out there. I know we've talked about targeted agents, systemic agents, but within the local therapies, there's lots of treatment options perhaps available. Some of them are already approved. Maybe they're not directly approved for cholangiocarcinoma, but if you start thinking outside of the box, perhaps you can start to apply those here. I will talk briefly about perihilar and extrahepatic cholangiocarcinoma and probably finish in 5 minutes if that's okay. Surgical resection, again, offers the best chance. Maybe transplants for patients who have perihilar cholangiocarcinoma, Whipple procedure. I'm sure a lot of you heard of Whipple procedure, where they resect the end of bile duct as well as duodenum and the pancreas, head of the pancreas. But if you can resect the tumor, it is fairly poor prognosis. Unlike extrahepatic cholangiocarcinoma, the local regional therapies for extrahepatic and hilar cholangiocarcinoma are even more limited. You can't use histotripsy, you can't use a lot of Y90 or TACE in these scenarios. So most often you rely on radiation as the primary treatment for the local component if they're unresectable. You can do conventional radiation. We talked about SBRT, but brachytherapy here is perhaps the most conformal and treatment, as we can directly get into the bile duct. I won't talk much about photodynamic therapy. There's only 1 or 2 studies on that. Conventional external beam radiation, most of the data comes from MD Anderson. At least I should say the best data that we know of comes from MD Anderson. Otherwise, there's small retrospective real-world studies, and median survival is about 12 to 14 months, which is in line with what is our best systemic therapy of gemcitabine, cisplatin plus durvalumab. Again, in the MD Anderson experience, what they were able to find that if you have patients who undergo chemoradiation, maybe additional chemotherapy, they can improve the survival to 18 months. We had this study, ABC07, which we often talk about in our tumor boards. Most of them are perihilar cholangiocarcinoma. Out of the 69 patients that were on this study, 84% were perihilar cholangiocarcinoma. They received radiation to the dose that I talked about, above 80 gray, potentially. But they only received 2 cycles of GemCis versus 4 cycles of GemCis. They did not use durvalumab or any other targeted agents as we typically give to our patients. Now, they found that progression-free survival was the same, but local progression, where patients actually, the local disease was controlled, was much higher in patients who received radiation, and the overall survival in those also improved. We know patients who present with hilar or extrahepatic cholangiocarcinoma, their time is spent mostly in the hospital because either their bile ducts are blocked, or if they have a stent, it becomes infected, it becomes septic. So if you can improve that aspect, you can actually improve patients' quality of life. And can they live longer because their quality of life is better and they're not out of the hospital? And that stuff we just haven't measured yet with any of these trials. We talk about that high dose of radiation. There's some studies with only 20, 30 patients where they tried to deliver that high dose of radiation. They were able to make patients perhaps live longer, but there's a high risk of toxicity that you pay when you give external radiation, especially at that high dose. Ulcerations in the duodenum, fistula or stenosis. And I just want to show you this picture. The dark, this is a very zoomed in picture of a bile duct area, the dark where it says the white duodenum. That's our duodenum, just the first part after the stomach. And right next to that is the gray little hazy thing, a circular. That's the bile duct sitting right next to the duodenum. And there's a tumor in the bile duct. Now, can you imagine trying to give radiation from external ways and to this bile duct? You're going to give same high dose of radiation to the duodenum. You're going to cause a lot of toxicity. So a lot of people are not even eligible to get that high dose of radiation because you're trying to cure this cancer. Now you're subjecting this patient to have ongoing bleeding that unfortunately lets them in the hospital. So hence, there's a high toxicity and many people don't do it. And some of the trials are not so successful moving forward. There are still some ongoing trials in this space. There's one trial in Belgium using this very high dose called SBRT after chemotherapy for unresectable perihilar cholangiocarcinoma. And it started enrollment in July 2024. Perhaps we can emulate the same thing here, and it comes from advocacy and funding. We should look at that. There's another trial open in India, but they're using more conventional radiation over 25 to 30 days. Started in 2015, still recruiting, tells you how long it takes to do these trials. So lastly, why I advocate brachytherapy in many of my patients who come with this hilar and extrahepatic cholangiocarcinoma. Now, brachytherapy is a way we can get access to the tumor directly, either putting a catheter inside or putting some needles. You've all heard of brachytherapy, perhaps in the prostate context, that patients can get seed implants or needles, and that's really giving radiation directly to the tumor. If the patients present, often you've heard that they undergo a process called ERCP, where the physicians can get access to the bile ducts. They put a stent. The stents can get infected, blocked. Oftentimes they need changing every 2 to 3 weeks, if not 3 months. You can put permanent stents, but they also get blocked because the tumor overgrows. Patients undergo percutaneous. They get a tube from outside. They have to live with that. Quality of life is affected. They can't bathe, they can't shower, they can't walk out. I had a patient, she wanted to go to a wedding. She couldn't fit into her dress because she had tutu bags outside. So there's a significant impact on quality of life. So brachytherapy, I think, really improves quality of life and it palliates, but it does have impact on overall survival. And we've done that. We looked at all throughout last 3 decades of studies done using this technique. And we found 17 studies, 649 patients when we combined all the studies together. Half of them received brachytherapy. The stent that we typically think only stays open for 2-3 months, if you deliver brachytherapies, on average, stents are open for 10 months. So you're already improving patients' quality of life. They're not coming back to the hospital again and again. Survival, patients who only received brachytherapy because they were deemed palliative, they did not qualify for any chemotherapy, was 11.8 months. Remember, I said even in the best systemic therapy, it's about 12 months. So this is, I'm going to give last 2 slides. My patient, Dr. Karen Nicholas, referred me this patient very long time ago now, about 4 years ago. Again, looking at patient directly like this, on the first panel, the gray area where the line is going, the yellow line is going, is all bile duct filled with tumor. And the same area on your right is a big circle just above the white crossing. That's a portal vein and the bile duct filled with tumor. We worked together. We asked our interventional radiologist to get a tube directly into that tumor. And we put and this is what the tube looks like when we were able to put it in the tumor, similar to what you have drained. And we were able to deliver a radiation dose which is probably about 2 to 3 times higher in each treatment, even if you were using external beam radiation. So you're really killing the tumor cells right in the stent, right in the bile duct. Our goal in this trial that we opened at Sunnybrook was not to maybe make patients live longer. We perhaps are seeing patients live longer, but can we keep them outside the hospital? Can we keep them, make sure that their quality of life is improved? Even if you have hilar tumor, meaning it's going to both sides, we have our interventional radiology colleagues, we work with them, that we can put 2 stents on each side and put 2 tubes, one going one way, one going the other way. And when we do that, we can deliver even higher dose to the entire hilum, such that we can keep that hilum open and keep those bile ducts open. And end result is most of them maybe either end up getting chemotherapy. So we started this trial at Sunnybrook in 2021, just during pandemic. Despite that, we were able to treat 45 patients, all with cholangiocarcinoma in a single hospital. We talk about rare cancer, but this speaks that if you have something trial open and if you advocate enough, and right now it's patients and physicians advocating to all the institution outside, that we can treat these patients and we can help these patients. And in our trial, we find that the stents are open for up to 20 months for many of the patients, median. Some are shorter, some are longer, but this is median. So that's my end of my talk. Sorry for taking a little longer.
Great, thank you. So we're going to have Dr. Jennifer Knox come up for the last speaker. We're probably aiming to have a lunch start around 12:15 or so we give a few minutes for the panel. And thank you for your attention.
All right, well, thank you very much to C3 for inviting me, Rebecca and Leonard. Full disclosure, I recognize I'm wearing purple to a green party. I have no excuse other than that. I wasn't thinking clearly this morning. I was jet lagged and I'm just happy to be here. So I was asked to address some of the barriers and potential solutions for opening more trials in Canada. I don't know if I have all the answers here, but I speak with some experience. I've been on the leadership tables of Canadian Trials Group for 25 years, advocating for biliary tract cancer, bumping into a lot of barriers, which are maybe Canadian specific. And I've also had leadership on the U.S. cooperative group, biliary and hepatocellular for 10 years and bumped into a lot of the accrual problems there as well. So these are maybe more cholangio issues, but we have some very specific problems ourselves. So what I'm going to talk about are some of the challenges and some potential solutions within our environment. Certainly, we've all been aware that in recent years, the complexity of clinical trials is growing. There's increasing delays to open them. And that rises the costs of doing clinical research significantly. And then when you have poor accrual, you've had some of the previous speakers mention this, it costs money to open a trial, and then if it doesn't accrue, it loses money. And then it builds that sort of nihilistic opinion that you can't do these trials. And then in Canada, of course, we have the large geography, and we're talking about a rarer tumor with rare subsets. So it's even harder. I think some of the solutions, which I'm going to talk about, which I think are very practical, is you have to set goals and metrics and meet them. It's how I've been able to, in my group, accomplish some things. We need to decentralize strategies because we're a big country and people live all over the place. And then we need to be open-minded about some new trial models. So I have my word cloud, which kind of represents more my clinician perspective on this. But you see hopes there, right? And just like with the patients, innovation, science is very important, but feasibility is such an issue. And so much of what we do, we have to find ways to get around these barriers and think outside the box a little bit. So some of the challenges, there's been a steady increase in the complexity. So the biomarker selection that Arndt and others have spoken about, it's here to stay. We got to find ways to do these trials more efficiently for these tiny subsets. We need reliable access to tissue. We need more support from our pathologists who are very stressed and overworked. And we need to make sure that profiling is available for all. And C3 has certainly helped widen that denominator. And of course, as mentioned, rarer subsets of rare diseases are even harder to accrue. There's laws around patient privacy that actually gets into the way of some ways to get data as well. So the way our different hospitals and ethics boards interprets the Private Health Protection Act is very variable, and they have very little tolerance for any risk. So, like, for example, many centers struggle with whether even a coordinator on our research team is allowed to screen a patient before the most responsible physician comes in. And that really limits access to planning for trials. I talked about the longer time to open, which leads to poor accrual. And there is an escalating cost to run a trial. I tried to get a number from my own institution, and I think it would vary on the trial and it would vary in the institution, but it costs tens of thousands of dollars to open a trial in a single institution. So if you add on more institutions, it becomes more expensive. That money has to come from somewhere to pay for the infrastructure and the people. And then if you don't accrue and you don't answer a question, then it's money wasted. And so what happens, I think, a lot in Canada is that different institutions prioritize where they can put their money and where they don't have enough patients and time. And what I've heard over and over again, is, well, we just don't have enough of these patients to make it worth our while, so we won't open a biliary tract cancer. Or we'd like to open your trial, Dr. Knox, but we'd rather do a colorectal trial or something. And so this is the reality, and it isn't that those institutions don't care about biliary tract cancer. It's just that they can't make it work. And so we have to start to think outside that. And I think the reality is that because of some of these issues, we've become less competitive and less desired globally for some of the trials. Arndt gave a good example of why we're not doing the second line FGFR trial, because we didn't have access to the first line. That was a regulatory funding issue that we've finally overcome. When I started out 25 years ago, it was different. We were considered to be a prime place to go to get clinical trials open, because we had this public healthcare system. We have healthy patients. They can all come in and see you. Everything was covered. And so we need to get back to being the most desired place to do trials. I think from Grant's talk earlier, the research is incredible here. And so I think this is really doable. And of course, this impacts patient care in a negative way. We're very aware of the world right now. The world's a crazy place. This is just to remind you how this is representing total expenditure on healthcare per capita in the world. And you can see that we're turquoise, which I think is kind of the sweet spot. We're similar to Western Europe and Australia and Japan. We have great outcomes in average survival and infant mortality and COVID out. So we do a lot of things well here. And we certainly spend some money on healthcare. And so, we need to look to global partners for collaboration, especially on these complex trials. Now, this is data from Princess Margaret I'm allowed to share. But basically, this was a look back a few years ago at what was going on. And so if you look at these bar graphs, the blue is telling you the median time to open a trial, and then the yellow is telling you how long the trial stayed open. So you can see if you spent less time opening the trial, you were more likely to be open to accrual much longer. But the numbers underneath that run along the x-axis, 0 to 2, 3 to 5, those are actual numbers of patients that are accrued. So again, from a practical financial point of view, it's a disaster to spend 5 months and a lot of money, probably 40 grand, to open a trial and have it open for 6 months and put 0 to 2 patients on. And so this is where we have to get a lot smarter in prioritizing what we open. And then when you open something, make it work. Okay. So obviously this is something that we're thinking about all the time. So one of the programs that we've had as a pilot is this institutional activation of 45 days. And I think what you can see is this isn't a pilot we're running to try to, if you look at the graph up at the top, or the bar graph, you can see that the average time to open a trial at Princess Margaret was pushing 200 days in previous years. It's outrageous. And what we're trying to do now is bring it down to 45 days. So that's not a small ask. It's a giant, bold ask, right? And that takes a lot of planning and intervention. I can't see what is under the bar thing here, but can I move this out of the way? Yes, I can. Good. So this takes real cooperation. So it's not only the fact that all the moving parts have to collaborate and work in parallel. The sponsor has to actually have all their paperwork ready from the beginning. Everything has to come together to be able to do it in 45 days. So I can tell you, I'm quite proud. One of the first pilots that went through was the Artemide adjuvant trial that Arndt talked about, which is the chemo plus immunotherapy for resected biliary tract cancers. I put it forward as one of the first IA-45s. AstraZeneca was on board. They went to bat. They brought all the paperwork in very quickly, and we opened it and launched in 45 days. So we were one of the first institutions to open this trial globally, and we already put like 8 or 9 patients on. So we're making a difference, right? So this matters. Okay, I did something. It's not advancing. All I did was move the little bar and it won't advance. So what did you do?
I have no idea. Okay.
So can I just test?
Yeah.
Okay, fine.
Good.
So Ontario Clinical Trials Ontario CTO has a similar strategy. So they've moved towards this is their leadership table recommendation. So they've moved towards activating trials in 45 days. They're promoting decentralized recruitment, which I'll talk about in a bit. Leveraging data platforms to facilitate research is something we need to build on. They have a program to capitalize on federal government money for rare diseases. I'd like to hear more about what that really is. Rebecca might know more about it. And more collaborative advocacy. So these are all very important strategies. Other solutions that can be put into place right away, building efficiencies into your own sites. Change begins at home. There's plans for a potential pan-Canadian ethics board. There would have to be some loosening of some criteria and risk tolerance to allow that kind of thing to happen, but it would be fast. Electronic consenting, as opposed to having the patient have to come in to be screened and consented for a trial, would really help. I've talked about the faster activation times. Quebec has set a goal for 60 days. CTO has also put in universal contracts, which basically means there's a template that every sponsor uses and will stick to. But there's been very little uptake of that so long. And it actually takes sometimes a very long time to get the contract signed between institutions and companies, even companies that you've worked with for 15 years, and know that you're reliable and everything. So that needs to change. We've had the pain of opening Epic, so maybe we should have some of the benefits now. There's the potential to share the chemotherapy builds, the tools that have been developed, and so to reduce some of the workload in other institutions if one institution has already done that work. So that's important. And regional consensus cooperation. I know it's a rare disease. Where's Ravi? So I saw you in action once. So down in Nova Scotia, you guys, as you said, you bring in all the different sponsors and different trials are presented. And then as a region, you make agreements. You can say, well, okay, we can't do that one, but we can do that one. So maybe you have some cholangio trials open, right? And you opened Artemide early, right? Yeah, well done. So that kind of cooperation should happen more often because we're a big country and traveling is hard. And then I'd like to talk a little bit about new models like the hub and spoke model and the platforms and master protocols, because I think they're the future. So it's abundantly clear to everybody here that to look after a biliary tract cancer patient is really takes a lot of cooks. It is complex and you need a lot of care. And so it's very hard to be away from home when you need all these different people for clinical trials. And of course, our geography is huge, right? It's bad enough to have cancer. It's another thing to have to pick up and move to another place and stay and incur those costs, right? So virtual appointments. COVID has taught us that it's okay to see a patient maybe every other time and do it virtually. And there's, I think there could be a move towards having some of the biospecimens, the lab kits mailed to patients and collected locally and sent back. So these are all things that we'd like to look into. So the hub and spoke model is this decentralized model where maybe you have a center institution that might be doing the lion's share of the work for the trial, but other aspects of the work can be carried out at local centers closer to home. And then, there's the potential for economy of scale there, where you put more patients on, you get more results, but in the end, you're not reinventing the wheel everywhere, and it costs less, right? So there is some success with this, but it takes a real openness to research at these different institutions where the patient may be closer to home. And it needs adequate, appropriate infrastructure and a willingness to do this. And so I think in the past, one of the problems I've bumped into is some of these out of Toronto sites want to join one of my trials, but they're not interested in a rare tumor, or they don't, they're not willing to put a little bit of the extra work in locally to get the tissue or to do the serial follow-ups. So it takes commitment to do this, but I think we have to do this for our patients. I went back and looked at the Canadian Cancer Clinical Trial Network, 3CTN, who have recently released a lot of information on how to have more remote access to trials in Canada, the CRAFT guidance. And I think they do have some metrics that show that they've actually been successful in some situations. And what they do is they actually provide extra money for opening and extra money for accrual to sites that open one of these trials. But it has to be an academic, peer-reviewed trial, and you have to come into it fully funded. And so the extra money might help that site join and pay their budgets, but it doesn't put the full infrastructure in that you need to get a pathologist or an interventional radiologist to get the tissue and all that kind of stuff. But I would say it's worth taking another look at it again today with the current climate. I just give you an example. This wasn't through 3CTN, but one of my own multi-omic trials in pancreas, we opened what we called Compass GTA. So across the greater Toronto area, we did the lion's share of the work. We brought the patients down, we consented them. We did the research biopsy there and we reported the genomics. And we sent all of this back to the local oncologist who also could help their patients with it. The idea was to open more access to trials. It's extremely very popular. It accrued rapidly. We couldn't keep up with the patients that were being sent, but we lost something. There wasn't the same robust follow-up of clinical data that you really want for your trial. And some of the serial sampling that we would have liked to have gotten didn't happen because the patients didn't want to come back. But having said that, I think it was overall a success. It's a learning process, not only for us, but also for those other sites. And I think I'd be very willing to try it again, building on what we've learned and try to make it a little better. These are just some examples of how decentralized clinical trial models can work. I just gave you the example of a translational research where the scientific part could be done at a central hub and then other care done locally. It's easy if there's a standard of care arm, maybe some of it could be given at back home where the patient came from. Like one of the best examples is actually the sequential standard and interventional. So my colleague Erica Sang has the Ablate trial. It's in pancreas as well. But basically it gets biopsy samples, which are done with us. And then it gets standard of care chemo, which the patient can then go back to where they are. And then at a later point, they get reassessed and they get the stereotactic radiation at that point, and then they go back for standard of care. And so it shares up the burden of the visit. So that's a good model. So here are some of the platforms of master protocols that I really think are going to be the future, especially in a rare disease like a relatively rare disease like biliary tract. So a master protocol is a clinical trial framework that allows the evaluation of multiple treatments or therapeutic strategies with a single overarching protocol. So there's the basket where many different disease sites have a rare mutation and they come in and they get the same treatment. So that worked brilliantly when KRAS inhibitors were first discovered with G12C, and they could bring in patients with lung cancer, pancreas cancer, and other things, colon cancer. So beautiful example. The umbrella study is where you have a single disease and then you have multiple different precision arms. Not so many successful stories in solid tumors, probably in an era in which the targeted therapies were not too effective. And so it's gotten a bit of a bad name. And I think the platform is just the same idea as the umbrella study, but it's more innovative and it's less rigid. So you're allowed to close arms and open arms and change them throughout it without it being too bureaucratic and too difficult, although it's a large lift to get it started. And so I like to talk about that a little bit because I think it's quite exciting. So the platform also can use Bayesian statistics, which is, I need Rob Grant to really explain it. But really, it means it evolves, the power evolves as more information becomes available in the trial. And so you may not need to use as many patients to answer the question as the data changes, right? And, some examples of where this has been successful, the iSpy platform was one of these in breast cancer. And this is a whole list of drugs that came out of that protocol. So maybe in a tumor site where you've got potentially really active new targeted precision agents, this can be a very effective way of getting those drugs to those patients early. And maybe in cholangio, we're moving into that era, right? And so it argues for it. There's one in pancreas cancer. They've struggled with getting interesting drugs, but they've been able to prove that one shouldn't advance. There's one in GPM, and as I mentioned, I think cholangio is ripe for this, and there is, in collaboration with the Cholangiocarcinoma Foundation and this Global Coalition for Adaptive Research, there is a program being built for cholangiocarcinoma, which I hope will eventually go global. So why does it really work for biliary tract cancers? Well, I think this could be written so that there's something for everyone. So basically, a patient can come in and get profiled at the beginning and then go on various different treatment arms that is a precision choice. And these are good hypotheses, and it can happen quickly, and those arms can change. What's important is there's a control arm, comparator arm, that runs through the whole trial. So from a sponsor's point of view, a drug company's point of view, your drug's being compared to that comparator arm. It's not being compared to another competitor drug. And so that should be appealing. We can also listen to what the regulators want. What kind of data do you want to be able to, bring this drug forward without a huge randomized trial? We can ask the sponsor, what question do you want answered about your drug? And then does it fit with what we want to do for our patients? So there's a lot of potential there. The other thing too is, and this is key, is that there has to be an arm for patients that's innovative, research sounding, but you don't have an identifiable target. So if you get screened and you don't fit one of those precision lines, you still get a chance to go on a standard of care plus something that might work for everyone. And so that means that from my point of view, pretty much everyone who comes through the door is going to get on that platform, and therefore I'm not spending $40,000 to open this trial and only putting 2 people on. Maybe I'll put on 30, right? So that's where I think really the future is. But this obviously would take a lot of collaboration, a lot of work. But I think it would give smaller sites the incentive to try to open something like this for biliary tract cancer. And then the final frontier really is artificial intelligence. And, there's just so much information, data coming from genomics, patient models, the clinical chart, the pathology, the radiology, and with this machine learning, hopefully all of this can be put into some algorithm that spews out a lot more information. And that's really the future, I think, that some of our young colleagues who have trained in this area and understand this a little bit are going to be doing now, and we're going to see in the next couple of years. So to conclude, I put my word cloud back up, and of course I'm putting my Canadian flag because how can we can't talk about anything right now without that. I just got back from an overseas meeting. There's a lot of US investigators, and there's a lot of concerns about how research is going to unfold in the US. So we have to remain or become, if you're not, competitive and attractive again. And I've given you some of these suggestions about how that will happen. Biopsying and profiling patients to keep all the doors open, it's here to stay. And I thank C3 for getting some traction in that across the provinces. We need to build our networks. I've been trying to build biliary for a long time, and I think it's really right now. If you open a trial from one of your colleagues or globally at your institution, accrue to it. Don't open it and then let it flounder, because it really fails our projects. And support the ones that are open now so that we build that accrual record. And then when these innovative models like the platform come along, think about it, how you can make it work in your institution. You got to think globally and new partners. We certainly benefit from the patient support and advocacy. We wouldn't get anywhere without that, and that could really help advertise these ideas. And we need to keep the pressure on. We need to work hard for the drug access. We need to streamline our processes. I just want to put a shout out to Insight. Not only am I delighted that Pemigatinib has finally got the go-ahead, I would like to thank Insight for actually not abandoning us when the roadblocks got a little bit ridiculous. So thank you so much. And it shows working with our sponsors is worthwhile. And I think that is everything. It must be. I don't have anything else. So I think that's really what you have to be an optimist to work in this area. And I honestly think we're moving into a period where there is a lot of hope, and Cynthia explained hope best I've heard in a long time, but it's true. And I'm really looking forward to the future. Thank you so much.
So I think we should still open the panel for 5 minutes, 10 minutes, so we can have the panel members come up. And our apologies to the patients in the room. Physicians never take lunch, so the fact that we saw an hour lunch in our agenda, it's like we had to bring it down to a half an hour. Okay, so please don't be shy, patients. Treaters, come up. Any questions for the panel? Oh.
Hello. Oh, great. Wonderful talks. Thanks so much. For Jennifer, first of all, just really a thank you for your leadership over the past several decades in this area. And you've been a guiding light and I think an inspiration for a lot of us trying to do research in the field as well. And your leadership has been incredible and helped all of our patients and all of our clinicians during this time. So thank you for that. A question, I really liked your slides showing the barriers, I guess. It's sad that we have to think of them as barriers rather than facilitators for doing trials in this area. The thing that I saw that I thought was maybe missing was some of the regulatory challenges with respect to Health Canada. And I wonder if you can, I know you've struggled with that. I don't want to say struggled. That's been a struggle in some of your past trials that have certainly delayed time to activation and enrollment and continue to, and we've struggled with them as well. I wonder if you can comment on what we can do to try to advocate with Health Canada to reduce some of those challenges and maybe make us more competitive. It seems to me we have the most difficult regulatory environment in the world, from what I can tell. And I wonder if you can comment on what we can do about that.
Okay, I left some of that out because I gave a talk not that long ago where I ranted and raved for 20 minutes about it. So, I think Health Canada's gotten better, to be honest. And in some of our problems, Health Canada hasn't really been the barrier. It has been the CADIS, the review for drug approvals and things in the country. In recent years, I've bumped up with Health Canada about what they consider to be control arms in some trials. And if you say a control arm or a standard of care arm isn't a standard of care arm, then it doubles the work of the trial in collecting adverse event data and things like that. And they are very bureaucratic, but I will say that they were open to discussion and would listen to our points of view and did change. And so we've also had Health Canada, along with other regulators, at the table at Cholangiocarcinoma Foundation and things to try to ask what are their barriers and why do they not accept some of our data. And it wasn't just Health Canada, but it was also FDA and the European Union and that. And their message, they put out a white paper. They've talked about it, but the real world data is important. The collection of reliable lack of toxicity is very important to them, and they love these platform ideas with the built-in control arm. So I think we might have the ear of the regulatory bodies, and I think they might not be quite as rigid as they once were. Honestly, I think we have to, now that, I didn't want to say this, but now that we've got pemigatinib and we're hoping things will move well with the provinces, I think we as a community should go back and look at what went wrong in that case and maybe use it as an example for this precision medicine and how to evaluate that better. Okay. Question next. Go ahead.
Yeah, hi, Flavio Roca from Portland, Oregon. Question for obviously anybody, the panel, but specifically for Arndt. As you know, I'm a big proponent of neoadjuvant therapy for intrahepatic cholangiocarcinoma, running the NeoGAP trial with my colleagues. And I was really excited to see the trial that you and Gonzalo are putting together. In fact, I was just on with Gonzalo 10 minutes ago. But the question is, this is a limited, population of patients, as we saw, 750, in Canada, probably about 8,000 or 9,000 in the US, something of that rate. And in order to move this forward, we have to be able to collaborate, right? We have to be able to design the trials because, Hop Tran-Cow has got a separate neoadjuvant trial at MD Anderson. So despite the current environment, can we actually work together, through CTEP and the clinical trials group in Canada to actually come up with a neoadjuvant trial for, North America?
I would love to say yes. Yeah. I think what at the moment happening is so unbelievable that I don't know, right? I mean, it's just not understandable. And I don't know how this will really change the way we interact in the near future. And then it's a very clear signal we are getting from the US at the moment, which I think is very concerning. Of course, I hope that we can collaborate, and we have seen it in Europe. And I think the good thing about trumpet that it unites Canada, Europe, and all other countries, right? And we have seen that we can do things together. So in our trials, we reach out to Spain and that helped us a lot. So I truly believe that doing these trials together will definitely accelerate, right? It's not only the number of trials, it clearly depends on the dedication of the partners. And being here with Gonzalo, it's just amazing. We have done a couple of trials in Germany. They all failed because the surgeons were not willing to contribute. So people like you and Gonzalo, I think, are key to do these trials. And of course, we would love to get these centers together to do it, but otherwise we will fail. But of course, we need to have the environment where we can do that. So I hope we will get there again.
Great. Rebecca?
Thank you. It's working. It's on now? Oh. Now it's flashing green to red. I don't know what that means.
You want to trade? Do you want to trade? Do you want to use this one, Rebecca?
Stephanie, anyone hear me?
Maybe just go up.
All right. Thank you very much for this session. It's very instructive. I want to ask a question which is just slightly to the side of clinical trials, or maybe it is clinical trials, but it's sort of looking at, for example, if you look at the NCCN guidelines in the US around targeted therapies for biliary tract cancer, there's a whole bunch of recommendations. And these are drugs that are for targeted agents that have been improved in other cancers, but have not really been tested in a formal randomized type of trial in cholangiocarcinoma. And yet they're available, and currently access to those drugs really is for people who are sufficiently tenacious to advocate to get the drug either from the company or from a provincial program, sufficiently wealthy to pay for the drug, or have been able to figure it out through their own private insurance. And the problem with that is, of course, many patients have no access, and we have no data. So is there a place, whether it's through Canada's rare disease strategy, where you could have something that isn't a Health Canada regulated trial, but it's a right to try with a full collection of data through a Canada registry, and patients could try these. They'd have to have safety data. It wouldn't be for brand new molecules, but for things that are already well vetted in other more common cancers. Do you see that as a potential path forward, and what would that look like?
I think we can definitely do that because we have now a very clear understanding of the genetic alterations in cholangiocarcinoma. So there will be nothing really new because we have done really this very detailed profiling and we know what we can expect, right? So, and I think the next step would be to really collect these data in a molecular registry, as you are saying. And we talked about Platon, which we have established in Europe, and which hopefully we can also bring here to Canada. And you, with C3, I think will contribute a lot so that we really collect these data and understand the impact of these genetic alterations on outcome. Yeah, and what I have highlighted in my talk, I think I'm extremely critical about the way how drugs are reimbursed here. But I think we have to acknowledge that we simply do not know the prognostic implication of these alterations. Yeah? So and I think this is something where we can contribute and where we can learn. And I think one of the major points was that Arndt said, we don't know what is the natural history of these patients. And if we are collecting these data now, and even for alterations for which we do not have drugs available, and there are many, right? If we lay the ground for that and understand what is the impact, it will be an investment in the future, and it will be much easier in the future once we have these single-arm trials where we get an outcome. And we know, okay, we can put it into the context. What would we expect? If they get standard chemotherapy, survival is that and that. And then we can understand whether it's beneficial or not. And then I think it will be also much easier and faster to approve the drugs. Yeah. So again, being critical is one thing. I think we need to change something. And Arndt had this approach of saying, we don't know. No, it's not possible. It's a rare disease. We don't do anything. I think this is completely wrong, right? We need to find solutions. We can question, we can have doubts, but we need to provide solutions. And this is something what we need to do. And I think what we are doing.
And if I could just add, it may be low hanging fruit, but the the tumor agnostic Health Canada indication for Pembro in MSI high, I think is a breakthrough, because I think for the first time the regulators are actually, especially in across GI tumors, is thinking, like there's not enough data in pancreas or biliary to justify that, and yet they acknowledge the scientific value of the cross tumor. So part of what I was hoping to, and I agree with everything you said about the collecting the data, but I think we need to challenge them to start thinking in this more targeted approach, where you're going to grow data from other tumor sets and combine it with your rare tumor set.
One more? One more quick one. Okay, just thinking of the platform trial and the question that Dr. Roca asked, and the interventional radiology difficulties of accruing to radiation trials. Would it be feasible to incorporate those arms into the platform trial too, doing neoadjuvant and radiation? I mean, not necessarily together, but.
Certainly. And then we've talked about within radiation oncology, the access to the types of radiation sometimes we can do here in bigger centers in Toronto may not be the same that you can get in, for example, Sudbury or Grand River or other centers. So that's one aspect of doing the radiation trials, especially in a rare tumors where the patient population is geographically separated. But having as hub and spoke model with platform built into it is perhaps best way to go, where you can actually send the radiation plans, for example. This is what we want to do, a central, and see if it's a right radiation plan, and then they can deliver it there so that the patient doesn't have to travel. I think that's the key. Right now, we're not doing that within the radiation field. So I think it's feasible if we are going spend a little bit more energy.
And can I just add, I'm a big fan of radiation in some of my tumors. One of the drawbacks of a lot of the radiation data in earlier years is there hasn't been that quality check of dose delivery and the planning in a central experience place. And so I think exactly moving forward, that would be an ideal place to actually get the experience and the quality.
So I think we'll end with, there's two questions online, and then we'll break for lunch. So I think these are patient questions, but regardless, questions that around how oncologists, treaters, whoever it may be, your surgeon, your medical oncologist, how they can stay on top of what clinical trials are available for patients. And the second comment is patients really not understanding why there's so many barriers to participating in clinical trials and not being able to really go cross-border and participate in a trial that may be in another province or country.
To answer the second one first, the barriers across provinces are not so strong. You can get your province to fund some of the care in another province, but again, the realism of trying to live your life and be with your family and everything so far from home is very challenging. That's why one of those models I suggested, where maybe some of the central difficult part, the delivery of something that can't be done locally, could be done at the hub, and then you could return home and have the standard of care part there and then follow up back. So I really think that's a solution. The problem with going to the US is that you arrive as an uninsured patient. And so even though the cost of the clinical trial may be paid for, all the standard stuff that the institution charges will be billed to you, and that sure as hell adds up.
Nope. Yeah. Okay.
I don't know what the first one was.
It's similar. Yeah. Okay. So thank you for your attention. We'll break for lunch, and Leonard's going to give us the details.
Yes.